Spine is a very sensitive part in our body.
Why is spine surgery so uniquely demanding?
Back pain can happen, but you should understand that you have a major issue. The patients start hiding their symptoms. Most common thing in recent times is a disc bulge, and usually every month I get 2 to 3 patients of around 18 years sometimes.
Is it common for people to live with spine symptoms for very long before they actually come to a doctor?
Where I do a lot of deformities with scoliosis, like the children come to me bending 90 degrees. I don't advise any young surgeon to attempt these surgeries without having navigation.
Right.
He cannot expect patients to pay huge amounts for surgeries because at the end of the day they are very expensive. And on the other hand, you are not allowed to charge the patients because you are in a society where lower middle class and middle class patients are 90% of your hospital's inflow. We don't charge anything extra for doing a robotic surgery. So I think this robot is hardly there in 7 or 8 centers in the entire country. Previously, when I was doing a deformity, it used to take some 4 to 5 hours for us. Now we are completing the same surgery in around 3.5 4 hours.
Oh, the robot is doing the surgery. Spine surgery will always be demanding, but with better planning, guided precision, and growing regional access to robotic assisted technology, like the one now available at KIMS Hospitals, Hyderabad, the conversation around it is changing from fear to informed confidence. Joining us today to talk about these advancements is Dr. K. Sri Krishna Chaitanya, consultant spine surgeon at KIMS Hospitals, Hyderabad. He has been pivotal in bringing advanced spine care, including robotic assisted spine surgeries, to patients across the Telugu states. Thank you so much for joining us, Doctor. We're very glad to have your company.
It's my pleasure to be here.
So, before we start talking about technology and surgery, Doctor, I have a question. We've actually observed in our research, and please correct us if we're wrong. Is it common for people to live with spine symptoms for very long before they actually come to a doctor? Is that true?
Spine problems are not very uncommon. They're quite common, but basically we attribute a lot of symptoms like back pain, leg pain, or neck pain sometimes, or any mild tingling in the legs, everything to spine. But actual spine problem, like actually having a big disc or actually suffering with spine, is very rare. So usually people what they do is they usually come to us or meet some general physician. They say that they have a back pain because looking at their age and looking at symptoms, they tell that you have spondylosis or something, or a software engineer or somebody who is working for a long time who generally comes to us. So once they tell that okay, you have a long standing back pain, more than 4 2 hours if you sit you are unable to sit, you have to lie down or you cannot walk for a long time, so generally they attribute it to spine. So usually they might not be because of spine. So actual spine problems are rare, but back pain is very common. If you take the statistics in India, like more than 60 to 70% people will suffer with back pain. 95% of the people, at least once, they find symptoms. So these symptoms are very rare, and people generally cannot tolerate for more than a month without treatment. But having a normal back pain or muscular ache or degenerative spine pain, these are quite common. With these people live for years together. Like people can come to us or meet somebody, some physician, and tell, I'm having this back pain from last 10 years. That is common. But if there is an actual disc bulge, like weakness in the leg, that usually cannot happen for more than 2 3 months, because after that it will become sometimes intolerable, and they really want to come to a doctor for some solution and all. So these are two different entities we actually should look at.
Doctor, before we get into the conversation about technology and surgery, we wanted to ask, is it true that, patients who have symptoms of spine issues, that they stay with the symptoms for very long, that they live with the symptoms for very long, and they come in for consultation after a long period? Is that correct?
Yeah, actually, we are thinking about two different entities. One problem is a normal back pain, which usually people have at least once in their life. Everybody will have more than 95%. And this has like symptoms of pain when sitting for a long time. Like they generally come to us and tell that, sir, I am working in a software company. If I sit for 3 to 4 hours, I'll start developing pain. Usually it settles down at rest. But now, recently, from the last year or so, or last 6 months of late, I'm having pain even for sitting after 2 to 3 hours. Usually it was like 5 to 6 hours, now at least 2 to 3 hours. Sometimes even this is reducing to half an hour or 1 hour. So this is a normal back pain. This generally happens because of weak muscles in the back, sometimes vitamin D deficiency, sometimes of lack of exercise, sometimes fatigue and all. So this cannot be attributed to spinal problem per se. But the other wing is where they have a real spine issue, where they have back pain. Sometimes it is very severe that they have to stop to go to their work. That means stop work absenteeism. That means like, sir, I'm not able to work at all. If I sit for an hour, I'll start developing severe pain, unbearable pain. I need to go to a doctor. I need to go, or I need to take over the counter medications. Sometimes this go down my legs and I am unable to walk, and I have numbness in the legs. I slightly feel little weaker. I was playing before last 2 months back. Now if I start playing, I'll develop some tingling in the legs, unable to walk, unable to sit. Sometimes even severe conditions, they also develop some urinary urgency and all. So these are actual back pain symptoms or actual spinal problem symptoms which cannot be tolerated for more than a couple of months. So they usually tend to come to the hospital. Even if I see a patient like in this second category, I tell them you go for physio. I don't find real weakness also in the legs. I tell them you do physio, take some medications. But they again come back to me in 3 4 days telling I'm not better. So then we have to understand this is an actual spinal issue. It's not a lifestyle related issue. So this has to be addressed by doing investigating him further, by doing X-rays or MRIs, and then we can take it forward with that.
So
So
there's a clear distinction between
definitely there is a
lifestyle
distinction.
issues and
Yeah.
actual spine issues,
Yes,
and
definitely.
I'm guessing that that's a common misunderstanding.
Definitely, because now patients come to me like they tell that I have a disc bulge, I have a spondylosis. So they come to me with a diagnosis which are actually very wrong. This is because I'm not telling all the doctors are wrong, but sometimes the relatives, sometimes paramedical staff, sometimes nurses or somebody who might be there in their relatives. They tell that okay, you have back pain from long time, you definitely have a disc bulge. So that is wrong. So they will be tuned as if they really have a bulge, and they come to me and say, sir, I had a disc bulge, I'm unable to bear the pain. That's actually wrong. They might not have any disc bulge. So after investigating for some time, after looking at their scans, after examining, I come to understand that it's completely normal, they don't have any issue with their spine. So that's what people actually should understand this very well, that all back pains are not spine problems, and spine problems may present with other symptoms. It need not be back pain alone, it can be something completely unrelated to back also.
That's very interesting, doctor, and that's a very important, bifurcation, like you mentioned. So when it comes to spine issues, we've put some phrases together, and you tell us if you get to hear these phrases very often from your patients. The first one is, "I just thought it was a bad mattress."
Yeah, they definitely tell, sir, I'm having a sudden catch in my back. So, and it's from last 3 4 days. I changed my mattress. It's too soft, or I'm using a spring mattress. I think it's just because of a bad mattress. Yeah, these are quite common. A bad mattress will be common. Sometimes they say that I had to bend down and pick up something. The day I was fine, maybe next day I started having this pain. But this is actual usual assumptions. It might be right, and sometimes it might be right, but usually they are wrong. It's the trigger which actually caused. For example, if I can say that if you think about the second category which I told, like actual spine problems, they have a chronic ongoing problem in their back with a disc bulge which is about to be prolapsed. Like,
Right.
so that day when he slept on the bad mattress, he had a prolapse. If it was not at that point of time, maybe today when he is driving a bike, he might get it.
Right.
So it's not the mattress or the bike which caused the problem.
That's
It
just a
is a,
trigger.
yeah, it's just a trigger. It's
Right.
the way lifestyle or the condition which has been occurring from the last 2 to 3 months, or sometimes maybe 6 months, and it's just a trigger.
Right.
Yesterday it might be mattress, maybe today it might be driving, or else if it didn't happen, maybe in a couple of days he'll have it when he's doing some other work. So it's just a trigger, but actually doesn't cause anything suddenly. Like it doesn't happen with a mattress in a whisker of time. Like
Do patients also sometimes say, "Oh, it's just a back pain. It happens to everyone. It must be normal."
yeah, definitely. Because now, if you take spine, actually, it's quite a sensitive area. Like if they come to a doctor, the patients, 90% of the patients come to me for opinion. That means I don't take patients directly. I only see patients who are already referred by some doctor,
Okay.
like who are actually having a spine problem, who are being suggested surgery most of the times, and they come to me for the final opinion, or they come to me directly for the surgery. Because if it's like just a normal back pain, I ask my juniors to see, or I generally ask the patients like, did you see any physician before coming here? So by the time they come to me, they're already afraid, they're very tense, because they might be feeling like if surgeon Dr. Chaitanya suggests a surgery, then I have to go for it.
Right.
So in that way they'll come. So whatever I say, they'll be in a mode of denial. Like they say that yes, doctor, it must be just a normal back pain. It will be happening to most of the people. So we might not require major treatments for this.
Right.
Like that they'll be telling. But actually they'll be struggling a lot. So once I try to examine them, once I take them through the process of their disease, like when did you have it, how are you doing? So I try to be a little friendly with them. Then they come up with things. Actually, I'm unable to bear this pain. I was like trying to do something like take a lot of painkillers. I was trying to not do any work. I didn't go to the office for the last 3 months, so I am not even performing well. All this they start telling. So at that point of time, I tell them like, see, basically back pain can happen, but you should understand that you have a major issue. But the treatment is very simple, and you need not get operated. Most of the spine patients even doesn't get operated. So it doesn't. It's not like if you go to an expert, you must be operated or you require a major treatment. It's definitely not like that. But the patients start hiding their symptoms, and they always say that they like they don't give the original thing because they're afraid of that. That's the reason the same thing comes to me. It's just a normal back pain, sir. It might come down in a while. That's what they ask me every time. Like they also tell me like that.
If you relate to this, remember you are not alone. So, doctor, when do these, regular pains, normal pains, when do these become red flags for the spine?
Yes, yeah, it's very important because usual back pain, for example, it's a young male or a female around 30 to 50 years. So if he has a usual back pain which settles down with a couple of days of rest, or it happens only in the evenings when working for longer times, or only it happens when they are using unusual activities. For example, for me, 5 hours is a normal thing. 8 hours is a little unusual. So for somebody who is working 8 hours every day, and he is having back pain on sitting for 2 to 3 hours from the last one week, it seems like a red flag sign. But somebody who is working only 3 to 4 hours every day, but suddenly he has pain after working for 6 hours, it is quite common. So if you take your lifestyle, and if you observe your lifestyle, and also you superimpose your pain symptoms, like, and you are unable to work as you are working before, definitely if it's more than a week or so, you have to meet a doctor. But if you feel like, yeah, I was working little more from the last week, maybe that's the reason I'm having pain, then you might you can take some over the counter medications, some pain balms or something, and wait for some time. It's not that emergency. This is one condition. The other thing is, if you have pain which is radiating down your leg, mostly a single leg, and sometimes you are feeling little weakness in that leg, definitely that means your nerve is getting compressed. So then you have to meet the doctor. So these two are the major things which usually it starts like that. Usually the spinal problem starts like that. So definitely then you have to meet a doctor. That's what I suggest.
Could you throw some light on other associated symptoms as well?
For disc bulge.
Yes.
So basically, in spine problems, the commonest thing is a disc bulge. So in these patients, you usually have pain when you try to bend forward. Sometimes when you try to cough, when you try to sneeze, you will have pain running down your legs. This is one thing. And if you are having these symptoms from long time, you might also develop some weakness in the leg. That means when you try to jump or you try to play some sport which you are already doing from long time, you might feel like you are not able to perform well, that you might feel that your leg is little weak. So this is another symptom. The other one which is in the last stages is like you might have to go to the washroom very frequently. Like you cannot hold it for more than an hour, maximum half an hour or 40 minutes, which you are able to do before. That too you are very young. Then these are the symptoms which tell that it's little it's going out of control. Then you definitely have to meet the doctor. These are the red flag signs.
It's fascinating that something as small as a cough or a sneeze
Yes,
is able to
definitely.
reveal so much about the body.
Yeah.
So, doctor, from your experience, what are the most commonly occurring spinal issues you're seeing in India today?
So most common thing in recent times, that too from the last 5 to 6 years, is a disc bulge. It's coming. It's become quite common. It's not at all uncommon because I do in a very high volume center, and if it is a Saturday or a Friday weekends, I see at least 30 to 35 patients. Most of the patients, 70% of them are in between 30 to 40 years of age. And usually every month I get 2 to 3 patients of around 18 years sometimes, or 22 years, with a huge disc bulge. And today I've operated 2 patients of around 30 years, 35 years, who had a very very big disc bulge with a complete radiating pain into their legs, who are being treated before from the last 6 months by other doctors. So they did not improve at all. So we had to do an
Go for
endoscopic surgery.
surgery.
So that's what I say. It's like becoming quite common. The major reason I think is because of lifestyle. In the lifestyle, first is the food, second is loss of sleep, because they are not sleeping properly. Some people work in the night for a week, again they come back to the morning, so their sleep pattern is not set. So we have to understand that sleep is the only thing which will regenerate our body. Like if you have a minor disc degeneration, at the time of sleep, the growth hormones and everything will be secreted, and it tries to regenerate. If you don't give body enough time to rest, then definitely it doesn't regenerate, and this keep on increasing and increasing. This becomes a cycle, and this leads to disc bulge, and this disc bulge also continuously increases. This is one thing. The second thing is food, as I told you, definitely less antioxidants, more of junk food, more oils and all. These they are not going to do any good to your spine because they continuously degenerate your spine. And there is a direct relation between less antioxidants and more of free radicals and degeneration of disc. The other major reason is smoking. So if I get a patient who is a smoker, who is very young, I think twice before operating because it's a very, very, very high risk candidate for failure of surgery. But if it's a non-smoker, thin regular exercise is doing, and symptoms are not for a long time, then definitely is a good candidate. So that's a very high relation of smoking to this one. Yeah. The most common spinal problems I come across is one is the disc bulge, the other one is spinal stenosis, and the next one is the spinal infections. Okay. And coming to the stenosis and infections, in spinal stenosis, usually they present in patients who are around 40 to 50, who are in the middle of their age. It's not very young, and they generally come from patients who are very hardworking, like they do some farming, they do some carpentry, all these patients. So it's in these patients have very common symptoms like when they try to stand and walk, they after walking for half minute or 1 minute, they'll develop heaviness in their legs, so they have to sit down for some time. So they commonly say that, sir, when I start walking for some time, I have development, I feel my legs are very heavy, they are not able to move. Once I sit down, it settles down. This is like that. Other thing is when they try to bend forward, when they try to bend forward or walk, or when they try to do cycling, they feel much better, because in these patients now, when they try to bend forward, the gap increases in the spine, the spinal canal diameter increases, so the symptoms settle down. So these are one common things. In these stenotic patients, we generally tend to treat them in the early of their early symptoms with physiotherapy.
Okay.
So to do very well, so we give back extension or back strengthening exercises, and we also tell them to avoid some things. If they are doing some carpentry, we tell them you sit on a chair and try to work, or to try to supervise rather than
Right.
working. All this we say. The other thing in infections, as I told you, infections also are increasing because of lack of immunity. In Previously, around 30-40 years back, we used to read that very, very less in chances of infection. Even in infection comes, they settle down without medications also most of the times. But now, because of children, now, they're not exposed to any bacteria outside. They are very carefully grown up. So when they come across some patient with infection, they easily spread to them. Tuberculosis is most common infection in India even now
Right.
in children. In the middle, it was the incidence was less, but now again it started increasing. So we come across many children with tuberculosis. In such cases, na, they tell that it's a young male or a female at 15 years, 20 years people who come to us and tell that, sir, I am fine but having vague pain. This pain increases in the night. I'm not able to eat properly. I'm reducing my weight a lot. I'm having fever sometimes at the night. All these symptoms they give. So then we have to think about spinal infections. So the most important thing here is if you can pick up spinal infections in that early stage, you can treat them absolutely well. You just give some antibiotic, you did do a biopsy, culture, give them antibiotic, they like improve. There is no need to go for any advanced treatments. So that's the reason in the stenotic patients and infections, we have to identify them in the early part
Early
of the life.
stages. Doctor, my next question to you would be, could you explain what's a disc bulge?
So basically, a disc is something which is a weight-bearing structure in our body.
Doctor, you mentioned a disc bulge. So, for the lay person, can you explain what that actually is?
That means if you are walking today, the entire weight from head to toe transfers to the disc.
Right.
So it is like a tire of our car. So it's a degenerative structure. That means it degenerates with age. So the disc in a young patient of 10 years is much healthier with a lot of water content, is much flexible. But the disc in the same disc when he becomes 60 years will become brittle, hard because of you wear and tear, because of degeneration.
Right.
So when you generally talk about disc bulge, this is a proper disc, healthy disc, which bulges into the spinal canal. That means the disc is little in front of the spinal cord. Whenever it degenerates, it comes back and hits the spinal cord. So this generally happens in young patients because they only are the patients who have a normal disc. When you cross your 40s or 50s, disc usually becomes very brittle and it mixes with the bone. Sometimes it integrates, the disc height also reduces. So disc bulge, if you are speaking about, is usually in young patients. So this disc consists of two things, which is an outer layer called as annulus and inner layer called as, it's like a toothpaste kind of liquid, which is called nucleus.
Okay.
So the basic thing, that the reason I am explaining you this is, in normal patients when they try to smoke or doesn't do regular exercise and all, the nutrition to the disc doesn't happen, because the disc nutrition happens with diffusion of elements. So when you try to exercise only, there will be movement in the disc, and that provides nutrition for the disc. So if you don't have
Okay.
proper nutrition, the outer layer starts breaking. It's called as annular fissures.
Okay.
So they'll be very painful. So if somebody comes to us with severe back pain, it's not radiating into the legs, sudden kind of severe muscle catch, but it usually settles down in 2 weeks. But this is not settling down. So they come to me, sir, I have muscle catches, but this time it's unbearable. I'm unable to move, and it's already a week or 10 days, and I have no improvement. So this pain looks like that. It's a sharp back pain. Okay, that means the annulus starts fissuring. So when these fissures happen again and again, there will be a big tear in the annulus. So when there is a big tear in the annulus, the inner nucleus or a liquid tries to pop out through the annulus and goes out and hits the spinal cord. So that
Okay.
is the disc bulge actually. So this nucleus can have two symptoms when it comes out. It can go directly and hit the cord, and it can cause a manual pressure on the nerve and cause a severe radiating pain. That is one thing. The second thing is this nucleus is an embryological structure which is not exposed to our blood throughout our life. Even when we are in the mother's womb, this is inside the annulus. So it doesn't go and touch our blood cells. So blood cells look at it as a foreign material. So sometimes even little bit of nucleus comes out, the all the WBCs will start going and attacking us, thinking it's something from outside. So that is a chemical irritation which can also injure the nerves. So these two kind of pains will come. One is a severe back pain with a leg radiation. The other one is simple leg radiation without back pain, where the nucleus will cause chemical nerve irritation. There, if you do an MRI scan and see, you don't find any big disc, a small fissure with a minor bulge, but the pain will be very high. This is because of chemical neuritis. The other one is a manual pressure where there will be a huge disc bulge, there will be a severe pain radiating, there will be weakness in the leg. He will have some episodes of annular fissure, at least from last 6 months, couple of episodes, followed by an episode again with leg pain. There
Okay.
it has popped out. So if you can pick up somebody at the time of annular fissure stage or just before that, you can actually avoid a major surgery in him. You can actually prevent disc bulge in him. So that's the importance of going and meeting a doctor when you feel that something is abnormal, and this time it's not like usual. These are the two things as I told you. Then definitely it take out some an hour or so in your afternoon times and just go and meet a spine surgeon and explain him what you are feeling. Definitely if you can arrest it at that point of time, and you can stop a major issue happening in your back.
So, doctor, for all of these concerns that you mentioned, I'm sure surgery is, something that needs to be done performed very carefully when it comes to the spine.
Yeah.
Uh, in your opinion or in your experience, why is spine surgery so uniquely demanding?
Yeah, what I feel is that spine is a very, very, very sensitive part in our body because it's a nervous system. So, unfortunately, the thing is, neurons develop only once in our body. Like, if there is a number of neurons in our, if God decides that you have some trillion neurons in your body, these are produced at the time of birth. That's it. Period. If one neuron gets damaged, you cannot expect it to reform again. And it's a single cell which starts from the spinal cord and ends in the leg. It's a single cell. You don't have connections in the middle. Okay. So what I say is, if you damage the spine while doing surgery, or if you don't diagnose properly, or by mistake if it damages or if it gets damaged because of the disc bulge, there is no way you can regenerate it unless it is a temporary damage. Like, it is just a praxia kind of thing. It's not a complete cut, or if it's not a complete damage, you cannot regenerate it. So in that way, in any other cell, if you take muscle or if you take anything, they regenerate, they form again to some extent, they form. But in spine, if we are not careful, or if we neglect something, like to the extent of getting paralysis, then it's very difficult for him to walk again. It's impossible for them to get to their normal life again. In the same way, when we operate, we have to understand the thing that you cannot manipulate that. That means you have to be very gentle. You have to understand that this is a very important part. That means if you ask a patient if you can live your life without walking, it's impossible. That's the reason I say whenever we operate a disc, we'll be very cautious, we'll take our time, we'll be very slow, we'll explain the patient regarding everything, and we do not operate unless it is 100% required. So always we try to look for another alternative, like, is this surgery the last resort, or is there any other thing where we can wait for some time, or which can make him little better other than surgery? So
Right.
these are the questions which we ask for ourselves. And the third thing which our boss, Professor Ashekran, when we are in our fellowships, used to tell, it's a family test. According to him, tells that if somebody in your family has this problem, are you going to do the same treatment?
Same thing.
So once we ask ourselves about these things, and then we go ahead with the treatment, then that's the reason. Because this is a very unique thing, and you cannot expect somebody to be normal again if you have a damage in the spine. So that's the reason it's very unique. Yeah.
What would you put as the margin of error while doing spine
I say
surgeries?
it's absolutely zero. I
Zero.
mean, like if you see my patients, I am here from last in this same hospital from the last 10 to 11 years almost, and I have two complications in these last 11 years. In particularly in I'm a pediatrics deformity specialist, so I do pediatric deformities. I don't say two one patient, and I still remember them because it's a complete U-turn of their life. If you have a complication, that is a life in
Right.
spine surgery. It's not like some other orthopedic surgery. I did
Right.
orthopedics before spine, so where it's a trauma, it's a fracture. Maximum it will go into non-union or infection. But here it's different. They will never walk again if you have any issue, and their entire life is completely dependent on the entire family, and the family has to bear the brunt of this person, and that's the reason. So we generally say that margin of error in spine has to be almost zero. It's
Got
you
it.
cannot expect any complications here. Yeah.
So this accuracy that we talk about, doctor, what are the two factors that it boils down to? Would it be surgeon experience and imaging guidance?
So basically, as we say that this is the most important part of our body, we cannot be wrong. So we need a lot of experience. We have many publications. Actually, I was an author for one of the publications telling the learning curve in spine surgeries. So how many surgeries a surgeon requires for them to become very good, like to minimize the error.
Right.
So we had many publications. What I felt was like if you take the educational system in India, in UK or US, where I was there in University of Michigan long time, the work volume is very less. That means the best of the best surgeons will operate only 10 to 15 cases every month. So what? But the thing different what they do is when I went there initially, I have to observe for him a couple of months. I was not allowed to touch. This is long back. So we see how this guy operates, and we see how this guy goes about his surgery. After that, slowly, after 15 cases, the surgeon stands on the opposite side and he tells, sir, now you take over. Now you try to do. So he'll observe how we are doing.
Right.
So if he feels that we are up to his expectations to some level, so he'll allow us to do. Otherwise, again, he will take it and again he will show us for another
Continue.
10, 15 cases. After that, he will ask us to finish the case, and this surgeon, who is the most experienced surgeon, will stand there from the starting to the ending of the surgery without moving. He will be there, and after that he will make us do some cases like that maybe for another couple of months. Then he will ask us to operate independent.
It's a very
uh,
slow
Very
handover.
slow, but it is totally supervised. You cannot expect the other doctor to leave the hospital or leave the operation theater unless we finish and we go out, then only he is allowed to go.
Right.
So that means it is under very much under supervision.
What about imaging guidance? Do you think that's also a
Imaging,
big
yeah.
factor?
See, when this is one thing, surgeon's experience, there is no doubt in that. You need to have at least 2 to 3 years of experience before you start operating of spine. So once this is done, there is a human error. That means you can be very experienced, you can do everything right, you can be well trained, knowledge wise, you might be the number one person. But God tells us that He is present by creating anomalies. That means the vertebra which actually have to be like something else will not be like that. There must be a dysplastic vertebra, there must be a totally abnormal vertebra. In that point of time, in that patient, you just cannot, you have to go wrong in that patient. So this thing cannot, it's beyond human things. So you cannot observe that, you don't know that it's an anomalous vertebra when you're operating. You might pick it up before preoperative CT, but even then it's very difficult. There comes the idea of artificial intelligence. There comes the idea of robotics and navigation, where you have real time imaging, where you can do a CT scan inside the operation theater, you can feed it into the robot, and even though you're experienced, you can do it without any guidance. If there is an anomaly, you will come to identify that yes, this is an anomalous vertebra. Here you cannot put a pedicle screw, you cannot do a laminectomy like that, you have to do a different way. And there is where the robotics comes, and that is where you can actually be better than human beings there. That's a imaging system. So this is very important. That's the reason we try to acquire the latest technology, and we want to promote robotics here.
Right. You said something that is, captured a lot of public attention. Robotics,
Yeah.
robotics in surgery. For a layperson, for
Yeah.
somebody who's not familiar with medical terms, it's very confusing, right? One might assume that, oh, the robot is doing the surgery, or oh, what role will a robot have to play? Is there an actual robot that's going to be operating? Because that's how we see it in
Yeah,
films
yeah.
and everything else. So please correct
No, no,
this myths,
actually,
doctor.
basically, I would be very happy to have a robot which will operate, but unfortunately, it's not like that.
Right.
It's not a robot walking into the operation theater. Robotics is something. It's a extended navigation.
Okay.
That means the surgeon is the only person who will operate. Nobody else will be there. But the only thing is, when you operate, it will guide you. That means what happens is, if I tell it is analogous to Google Maps. For example,
Okay.
which when you have a Google Map, you have a map there, and you will navigate over a map. Your
Right.
car has connection to the GPS.
Right.
In the similar thing, if Google Maps is for the entire world, but here it's the operation theater which is navigated.
Okay.
Okay, there is a satellite kind of thing which is a navigation camera in the operation theater, which maps the entire operation theater, and you have a small map inside which is done by the CT scan of the patient.
Okay.
So whenever I am moving my arm, I will know my arm's position in the operating theater, which is superimposed on the patient,
Understood.
which is given by the navigation camera. That
Understood.
means, for example, I do a CT scan of the patient, send it to a navigation, and on that map, on the CT scan of the patient's vertebra, I will be moving, so I will know where exactly I am. I will know how deep I should go. I will know which direction I should move. Which I will. It's like the navigation which is moving on the scan.
Very much like maps, like you said.
Is absolutely the same technology. It's nothing different. It's
Okay.
very simple. But the only thing is Google Maps can go wrong. That's the same way you have to be very sure when doing the CT scan, when arranging the navigation, you have to do it. It's not Sundar Pichai or somebody who has
Of
arranged it for
course.
us. So we have to make sure that the patient doesn't move, the CT is done properly, the navigation camera is oriented properly, and also if map goes wrong, we should be knowing the directions.
Yeah.
That's the thing, we should be checking it always. It will be correcting us, so with experience we'll get it. So we'll start off with small surgery. We have done more than hundreds of surgeries with robotics also. So robotics is very safe in the hands of an experienced surgeon. If the surgeon is doing 97 times right, if he wants to become 100, right now it is navigation or robot has to be there. That is the truth, and everybody accepts that. It's published also. And there is no other alternative, because computer and equipment always makes our life better. You are a very good calculator also.
Right.
You can do things in your mind. Even then, if you have a computer, you can recheck them.
Yeah.
You cannot go wrong. That's the advantage of robotics.
So, doctor, in the research we found the Medtronic Mazor. Can you tell us what this system is and why is it so powerful?
Yeah, the Medtronic Mazor is the most advanced robotic systems which is actually present right now. So it's a system which is we imported it from USA. It's originally developed in Israel. So basically, what this does is you have a navigation in hand. That means, like, you have a map, you have a patient navigation system ready, you have an introp CT. But in this system, when you actually mark a pedicle, like when you want to do some cut in the spine, like you just take a CT scan, you put it on your computer, and you plan it
Okay.
before the surgery. Like before starting the surgery, you plan that I need to do these pedicles, I need to do a discectomy here, I need to do a screw here, like everywhere from T2 to L4, any part you can just mark it up and plan, and you just tell the system that I need to go to T2 pedicle right side.
Got
So
it.
the arm directly moves onto the T2 pedicle right side, and it marks that point. So you just have to go and do it through the arm. You need not go and you need not search for anything.
That's lovely. But do you think it's necessary for all spine surgeries?
Definitely not. See, if you want robotic surgery, it's well and good for every case. But if you really ask me the indications for that, I would rate number one as pediatric spine. Where pediatric spine, the pedicles are very small, the children are very small, you cannot afford blood loss. So you want only one shot, and you have to finish off the surgery in a single shot. Then definitely I would say robotics is game changer in that. The second thing is deformities, where scoliosis. I am a pediatric deformity surgeon, where I do a lot of deformities with scoliosis, like who are very big. Like the children come to me bending 90 degrees, 80 degrees, like very, very highly bent surgeries. In these cases, I would say robotic or at least navigation is a must. So in these obese patients, very fat patients, in revision surgeries, where the surgeries are already been done and you have to revise that, maybe due to the failure of the surgery, or maybe due to the long term, again because of development of disc bulge again for the second time, in these surgeries also, you better have to have robotics. But the absolute indications are pediatric spine and deformities. These have need to have robotic. There is no doubt in that.
So, would it be right to say that the more complex the anatomy of the patient,
Yes.
the more value robotics would add?
Definitely, in complex anatomies, there has to be robot because you otherwise you might land up in as you might end up damaging the nerve
Right.
at the end of the day. Yeah.
Doctor, when we talk about robotics in spine surgery, especially accessibility is a very,
Yes.
is of lot of importance. And from what I understand, it was your team at KIMS that introduced robotics in spine surgery in the south of India. How did you make that possible, and how were you introduced to this
Now,
surgery?
basically, it's a very big demand from our side. For our management to accept this demand is also very great because when I met Dr. Abhinay Garu and Dr. Bhaskara Garu telling, "Sir, I think we need to move ahead with the latest technology," then I thought that they will say, "Okay, we'll see." But I was very, to my surprise, and I mean, like, it's very, very, very good to see that Doctor. They told that okay, we'll go ahead. It didn't take even 5 minutes for them to accept my request, because I say that it's not a small thing. In a country like India, where you cannot attribute, there is not much of support from the society for this technology, because as we know, still we are developing. We
Right.
cannot expect patients to pay huge amounts for surgeries, because at the end of the day they are very expensive.
Right.
The reason that it is the first in AP Telangana is the only reason is because it is expensive. Otherwise, everybody would like to have it in their hospital. So when such expensive equipment comes, and on the other hand, you are not allowed to charge the patients, because you are in a society where lower middle class and middle class patients are 90% of your hospital's inflow. Now also I say that we don't charge anything extra for doing a robotic surgery, because this is something we look at. Okay, the surgeon will develop, the patients will be benefited, the hospital will get a good name, we will give it free of cost. That's what actually we were doing from the last 3 4 months, when since we acquired. We are not charging anyone. It's as simple as a normal spine surgery. It's not expensive at all, but the difference it makes is priceless. There is no doubt in that, because I worked with this robot in 2016 in USA. From then, 10 years it took for the
Right, to
same
come to
robot to
India.
come to India. But now, when I went to US last year, every hospital has this. Everybody has this, and I'm sure when we go next 10 years, 15 years down the lane, everybody in Hyderabad will also have this. There is no doubt in this. The only thing is, in our country, it's little late that the technology comes, but definitely people will adapt to it faster. There must be some training opportunities also, and even if the price also comes down, it makes wonderful results, and it's very good to see that.
Beautifully said, Doctor. And it's very relieving that people in the Telugu states can access this so easily without,
Yes,
much
definitely.
of travel involved or anything else. You also mentioned that, Medtronic is one of the strongest systems, but it is slightly unfortunate that the access to it is still limited and not
Definitely.
many centers in the country,
Yeah.
have access to it.
Very few centers. I think this robot is hardly there in 7 or 8 centers in the entire country.
Okay.
And the one which we acquired is the latest one. It's a new version of Medtronic Mazorix, where, as I told you, maybe they promised that maybe in a couple of months they'll take away that code. Like, we need not pay any premium to the
Right.
country or whatever it is. So maybe if this happens, then it's very good.
Beautiful.
Yeah, it's good not only for us, but everybody else who have acquired this, and more people might be thinking. I heard that another 2 3 hospitals are looking at acquiring this technology. If that happens, it is very good. Like, patients will get access, and patients will be comfortable going for spine
Right.
surgery, because they understand that the
It'll,
risk will come down, and risk is equal to safety, as I told you.
it'll
The
become
more
the
safer it
norm.
is, more happy will be the patients, and the technology also will grow, and surgeon also will have a very, I mean,
Peace of
while going
mind.
to the OT, we'll also be very comfortable, because we are already sure that we are not going to have any complication. Most of the complications we can avoid with this by using this. Yeah.
Doctor, one thing you mentioned that stood out to me particularly was the use of robotics in pediatric surgery. I've heard that you've also used the system on children as young as 6 to 10 years of age. Can
Yeah.
you talk about that?
Yeah, actually, the youngest child which we have used is around 2.5 years. It was a craniovertebral junction surgery, where the pars diameter, that's the pars is one part we actually try to instrument in these cases, and that's only 2.7 millimeters. So we had to put a screw which is less than 2.7. So that's where robotics makes a lot of difference. And multiple patients, like 6 to 7 years, we have done at least 4 or 5 cases, like robotic surgery. It's normal surgeries we have done multiple, and between 10 to 15 we have done some 8. Yeah. So pediatric surgery, it's hands down, it's definitely useful because the time I was taking before, and the blood loss I was having, the stress levels, the radiation exposure, everything is at least 80% down now.
Right.
So we are very comfortable. We are 100% sure that we are going to do a good job because we have a technology which is state of the art, which is beside us. So it is supporting us in each and every step.
Right.
We also have a monitoring system which is along with the robot. There are some technologies like nerve monitor,
Right.
intraoperative neural monitoring. That's also very important. It's there for a long time, but in the middle, there are a couple of companies who have backed out, but again they come back into the market. The reason is if we have a very good nerve monitoring, that means when you are operating on a child or operating for anybody, it doesn't matter a child. When you touch the nerve or when you get close to the nerve, you get a signal on the monitor. This is called as nerve monitor. That
Lovely.
means indirectly we try to send some currents from the skull and we try to record them at the feet. So when there is an interruption, you get it, you get to know immediately.
Immediately.
So you can reverse the procedure or you can stop it there. So that is one way you can prevent nerve injuries. Along with that, if you have a robot, it's definitely you can have 100% results. So nerve monitor, and in these children around 6 to 10 years, we have done multiple cases. In these patients, we have actually felt that we have reduced the operative time by at least 50%. Previously, when I was doing a deformity, it used to take some 4 to 5 hours for us. Now we are completing the same surgery in around 3.5 4 hours.
So, doctor, despite the confidence you have in the procedure as a doctor, especially in complex cases, especially when kids are in the picture, I'm sure patients have two questions. One, is it safe? And two, what is the chance? What is the margin of an error? How do you respond to these queries?
Yeah. And as you ask me, these two questions are very important because whatever you say, complications happen. So it's you have to sit with the family. You have to explain them that this is required, and this can also happen. You have to tell them everything as it is. There is nothing to hide. So then even the family members, the grandparents, the parents, sibling, I mean like the other brothers or sisters, everybody comes to us because they are too young to understand these
Right.
also.
Yeah.
So we tell them, we explain them, fingers crossed. But something very good is we don't have many complications because this technology, if it improves a little, as you asked me in the initial, really if the robot comes and does
Yeah.
the job for us particularly 100% right, then it will be very good.
Right.
But right now we have very 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 less failures because if you identify children at 13 years, actually it's much better than rather than to delay and operate them at 25 26 years.
Doctor, we never touched upon what are the deformities that you usually operate upon.
Yeah, we operate on multiple cases, but I get mostly congenital deformities,
Okay.
congenital neglected deformities, like
Could you explain that in a little
yeah,
detail?
that means see, there are deformities of three different. Usually, completely, it's like if you take the broad spectrum, it is three different types. One is a congenital. That means by birth, a child has a deformity. So now, actually, some people ask me that if it is from birth, why don't they detect them in intraoperative uterine thing? But sometimes they tend to miss them in the intraoperative scans. They have a small vertebra which is abnormal shape. That means instead of being like a square, it's like a triangle. So because of that vertebra, the entire spine bends to accommodate that vertebra and becomes a huge deformity curve.
Understood.
So if that triangle is observed at 2 to 3 years of age, and if that hemivertebra is removed at 5 years of age, the entire spine will become normal. But if you allow the entire spine to accommodate for that, no, because of that hemivertebra, the child will become like 80 degrees or 100 degrees bent, and he comes to us. Then, not only to remove the vertebra, we also have to correct the entire spine. So this is a very difficult problem now. It's a simple thing which has been neglected becomes difficult. This is congenital deformities. So the idea of school screening programs is to identify the congenital deformities. But if you take adolescent deformities, that is deformities which develop at 9 to 11 years, mostly in women, when it's like female childs, and in that deformities because of hormonal imbalance, because of melatonin imbalance, sometimes because of genetics, sometimes because of other ligament issues, they develop deformities. The actual etiology, the actual reason is not known. So they tend to start at 10 years and increase till 22 years. So in these children, it's quite easy. This is a second spectrum. Usually we don't have any complications unless they come to us at very late stage, like 18, 19 years. They'll be quite flexible. It's easy to operate. The other spectrum is the neuromuscular scoliosis deformities. That means where they have polio or they have some cerebral palsy, they have muscle weakness, spinal cord abnormalities, which are major cause and they lead to secondary deformities. In these children, we actually see their life expectancy, like if they are able to sustain independent life. If they are independent walkers and able to work, then we try to correct the deformity so that they can at least sit and they can have a good cosmetic life. But if you feel that they have some very severe neuromuscular atrophies or very poor life expectancy, then we try to treat them with braces throughout until the time they survive. We try to treat. We don't generally try to operate in such cases. Yeah,
I'm sure it's life changing for your patients, like
definitely.
changes the course of their entire future.
Definitely. I have at least 120 deformities with me, and I remember every child with their name, with their parents' name, address, everything. Like, it's so happy for us to operate on these kids and to make them normal again, because the entire life, whichever they lead, they will remember us, and we can also think that we have changed the life of a small kid. Because at that point, when they come to us, even they don't know what they're undergoing. But after some time, after 5 6 years, once they grow up, and my oldest kid is when was operated was around I think he was around 14 years when I first started my deformities. Now he is 25. Now I saw him last month and he came to me. He's quite happy. Now he understood what surgery he
What
underwent, and now
the
at that point of
complexity of
time,
the
the
situation.
complexity of the gravity of the situation, he doesn't know at that point of time. Now he is very happy. He came to me to invite for his wedding, and it's very good to see children who grow up and who become good. Like, yeah,
How sweet, doctor.
yeah.
Talking about the future, and I know we joked about this. We said, oh, maybe in the future robots will be the ones doing the surgeries. But realistically speaking, what do you think the future of surgery, especially robotic surgery, looks like 10 years
Yeah,
down the line?
robotics, exclusive, especially in spine. See, you have robotics in abdomen, you have robotics in joint replacement. As you said, they're independent robots. That means the surgeon can just stand there and see the robot operate. In knee joints, you have where you can just plan and wait for the robot to operate. But in spine, yet we don't have that because it's very sensitive. If it goes wrong, you cannot go back and correct it.
Right.
So you have to operate. It will just guide you. That's it. Maybe in future, maybe once this technology is very good, maybe you can simulate the robot. We can add artificial intelligence to some extent in this robot so that it can take its own decisions and it can simulate and show the surgery before to us, so can we can approve that and maybe it can continue the surgery. Maybe we have to see that if it comes. And also, this navigation GPS is working properly. It's quite good, but the camera and all the sensitivity should increase definitely, because sometimes we have to move the camera, sometimes we have to readjust. So if they are more sensitive, if the technology increases more, definitely it will make a lot of difference. Because I think that there are many places where navigation is used apart from healthcare, which is very good, much better than what we're using in healthcare. So if the same technology, if our government also gives us some these things so that we can spend more time in R&D, so that definitely the same
There's a scope
yeah,
for
there lot of
growth.
scope is there.
Lovely, lovely. Doctor, we've been talking about robotics, right? And when we say robotics, words like advanced, precision, AI, all of these terms come out very often, right? These are things that everybody is aware of. What are some lesser known, benefits or lesser known advancements in robotics that like a layperson wouldn't know?
So basically, when somebody thinks about robotics, they, as you said, AI, advanced precision, and all we think about. But the lesser known things, which actually everybody should come to know, is that robot actually reduces your workload. Like, you can finish the surgery little faster than you actually try to do. Like, we take so many CM shots, we are exposed to radiation. Not only as the patients are also exposed, so this is dramatically reduced in robotics because now it's navigation. It doesn't have any radiation. It's just a one shot, and you integrate the navigation with the robot. So you are away from radiation. So
Right.
that is one very, very, very big advantage of robotics. Rather than precision and all, if you ask me the other advantages of robotic surgery, the first advantage I will tell you is smaller incisions. The lesser the cut on your body, the safer will be the surgery, the faster will be your recovery. There is no doubt in that. So with robot, we tend to have the least size of incisions. So definitely the patient will walk through out of the hospital way better, way faster, and way happier than the other normal surgeries.
That's lovely. That information, that confidence, that consistency, all of this in a surgery, that's got to be very powerful. I think this begs the obvious question, doctor. If it is such an important part of surgery, why isn't this being adopted by more and more hospitals?
The major reason for that is training. The second thing for that is financial issues. because it's very expensive equipment. First thing, the other thing is once this equipment comes to multiple hospitals, there'll be training opportunities also. So it's very difficult to get a training opportunity. Apart from India, there are multiple countries to offer, but going to other country, getting the approvals in that hospital is also very difficult.
So it's not just technological adoption, but it's a system level change.
Definitely, it's a system, and things should not happen fast because
Yeah.
it will take time.
Take
Because
time.
no, with time only the experience comes.
Yeah. Certainly, there's hope for everybody who might need it. And thank you so much, Doctor, for having this important conversation with us today. We've opened up our minds about what is robotics in surgery, especially spine surgery. Thank you so much.
It's my pleasure to be with you here, and it's a very good studio with a good ambience, and we had a very good talk.
Chat.
And hopefully, it goes to the patients in a very nice way. And most of them, if they have any doubts or anything, na, they can actually go to multiple website. SRS website is there where I was working, where we are members of Scoliosis Research Society, srs.org. There are multiple websites also, so people can visit that, and they can get used. They can get, if they have any doubts, they can search in the internet regarding. Thank you for inviting.
Thank you so much.